So tips and tricks for ceramic onlays. First and foremost, I want to make sure that the people that are here with us today in the morning follow us on our different social media platforms. Don't forget to visit our webpage, www.romerodentalseminars.com. If you visit our webpage, don't forget to subscribe to our webpage so that you can get email alerts on every single one of our presentations. You can also follow us on Instagram and on Facebook. We also want to thank our sponsors, Colteen and Oral Arts Dental Laboratories, for making this webinar possible and for allowing us to be part of your Saturday morning. Again, this is our webpage, www.romerodentalseminars.com. If you visit our webpage, you can always click under the webinars link, and you will have a list of our upcoming live webinars that you can subscribe early on them. We only allow up to 100 people to be part of our webinars at a single time. You also have a link to our on-demand channel, where will automatically take you to our YouTube channel, where you can see all our 71 webinars that are in our YouTube channel at this point, and you can view them as many times as you want without any restrictions. This is what our YouTube channel looks like. And please, when you visit the YouTube channel, don't forget to hit the little bell to subscribe to our channel. And that way you will also get alerts every time that we upload a new video. So let's start with our tip and trick number 1, caries management. So, caries management is one of the, in my mind, one of the most discussed topics that we have today in restorative dentistry. This is a really nice manuscript that was just recently published by Robles and Lawson. And, what I like about them is that they really went into details on the way that you should be managing caries today. And this is really the way that you should be doing this in order for you to maintain vitality of the teeth. Now, we all know that, in many cases, caries has progressed to a point that there is no point of return. You already have a pulp that is either damaged, or you already have a necrotic pulp. So, in those situations, this doesn't apply. But when you still have vitality, the ideal management of these lesions is to try to prevent getting into the pulp, trying to prevent exposing that pulp and just creating, in my mind, at least from a restorative standpoint, just going downhill from there. Because we all know that, yes, root canal treatments are a good option when there is no other option. But the best situation that you would be able to, or the best way that you can handle or restore a tooth, is by actually trying to maintain as much as you can vitality of that tooth. And there is a way that you can do that if you understand the way that we are treating caries today. Now, there's 2 things that I want you to be aware of that we all know. You've heard about infected dentin, you heard about affected dentin, and you know that the only difference between one or the other is really bacterial content. So I'm not going to go into the details, because I think that we all agree that we know exactly what that is. But what I do want to make an emphasis on is the way that we manage these caries. Many of us have been trained old school way, meaning that we want to try to remove all, as much, if not all, the caries lesion present on the tooth. And we try to visually assess this. So, from a tactile standpoint, it's really kind of hard to tell the difference between the outer caries layer and the inner caries layer. They both are going to have soft dentin tissue. So there should be a better way for us to be able to analyze the caries, the remaining dentin, the affected and the infected caries, so that we can manage both of them in a different way. So the number 1 thing that I want you to keep in mind is what we call today selective caries removal, which means that you're not going to remove all the caries. You are going to select the area of the tooth. And this is obviously when we're talking about deep caries. Please don't think about this when you're talking about superficial caries, because you have enough dentin to protect the pulp. But when you don't have enough remaining dentin thickness to protect that pulp, that is when selective caries removal is ideal. And it's ideal because the studies have shown that when you do selective caries removal, there's a 77% lower incidence of exposing the pulp. And that is crucial, because if you do expose the pulp, obviously, at this point, we all know that affected dentin also has It has less, but it still has some bacterial content. But infected dentin is where that bacteria has really progressed and has eliminated all the remaining mineral part of the dentin, and that's why the dentin is so soft, or even sometimes even leathery type of sensation when you're actually trying to remove that caries. But the most important thing here is that we have to understand that there is a possibility where we can leave deep caries, soft infected dentin on top of a specific area of the tooth. And I'll talk a little bit about that when we review another article. But I want you to understand that when I say specific area of the tooth, that means that there's other areas of the tooth where the dentin and the enamel have to be 100% clean. That is what selective caries removal is all about. So selective caries removal is not, I'm going to just leave caries everywhere, even in the enamel, but I'm just going to make sure that I remove the majority of it and then restore it. That is not acceptable. Selective caries removal is removing the deep caries on the dentin that is closer to the pulp, cleaning everything else around that dentin and making sure that you have 100% clean enamel. We also know today that we can bond to that caries. We can bond to that infected dentin or affected dentin, depending on the situation. Do we get the same quality of bonding that we would achieve in nice and beautifully clean dentin? Well, the answer to that question is no. We're not going to get the same bonding effect or efficacy, but we're going to bond to it and we're going to be able to seal it. And by sealing that, we're going to be able to control progression of the disease, meaning that we know today that by the means of sealing dentin, that deep caries dentin, we're able to arrest the progression of the disease. And that is what we have to really value with this type of techniques. So again, you just want to make sure that you selectively remove caries, because that's the way you want to keep teeth vital. And this is when you have teeth that are still vital even though they have caries. Now, this is another paper published in 2012 by Dr. David Aleman and Dr. Pascal. You most likely have heard of these two people, and they are very into this immediate dental sealing concept, or this biomimetic type of approach of concept in dentistry. And that's really what I'm going to be talking about today. I'll try to make the differences between biomimetic dentistry and just conventional dentistry, conventional restorative dentistry, that there's nothing wrong with the other option either. I'm just telling you that there's two different philosophies today, and you just got to figure out which one works best for you. I am going to tell you right now, I prefer the immediate dental sealing, the biomimetic type of route personally, because clinically it works very well in my hands. But I do have to say that it is more common. It takes a little bit more skills. There's a lot more steps involved. There's a lot more that you got to look into before you make that decision. But this is a type of dentistry or a philosophy in dentistry that works very well, and that its ultimate goal is to preserve as much tooth structure, healthy, solid tooth structure as possible before you go ahead and do any type of indirect restorations. And again, I'm going to show you some examples of that. For now, I want to go ahead and I want to review this systematic approach of deep caries removal when we're talking about biomimetic dentistry. And this is really what selective caries removal is all about. The number one thing that we have to understand is understand caries first. We know that caries has an outer layer and an inner layer. And we've all seen this because when we're working on teeth, we have seen that, that light browns, very soft, leather texture type of caries that is more superficial, would be the outer caries dentin. And once you remove that, we've all seen that inner caries dentin that is more transparent, that actually, many times we can tell that there's a live pulp tissue underneath. That would be the deepest layer of the inner caries dentin. And that's why this is so crucial, because now you have to understand that there are other concepts in dentistry that we have to obviously understand and know, which is the remaining dentin thickness concept, which states that you need to have at least 1 millimeter of remaining dentin thickness to obtain 100% protection of your pulpal complex. Now, is this always possible? Well, today we know that it's not. Because if you remove that outer caries dentin and you are able now to see more of a transparent or translucent dentin below that layer, you know that you're so close to the pulp at this point that you don't have enough remaining dentin thickness. So if you don't have clinically enough remaining dentin thickness, you're going to have to replace that dentin with some kind of materials. And that's understanding of biomaterials today as well. So again, that inner caries dentin, 3 layers, the tubered layer, the transparent layer, and the subtransparent layer. You are seeing that in my graph. And the only reason why this is here, this is directly from this article. The only reason why I put this chart here is because it's easier for us to visualize and understand when we're working clinically, what is it that we're looking at and how much of this outer caries dentin you really want to remove. If you look at the image on the right and the image on the, on the left-hand side and the image on the right-hand side, what you see on the right-hand side is what you don't want to do. You don't want to be aggressive at removing caries. You don't want to go in and remove all the caries. You don't want to use that older philosophy, older concept about managing caries within our patients. Because if you do that, the risk of you getting into that pulp is very, very high. And once you get into the pulp, there is no turning back. You're not going to be able to seal that with an adhesive system, because we all know that there is a cytotoxic effect when you have direct contact of any of these adhesive systems with the pulp. So that's something that you don't want to do. You don't want to be placing any type of, well, you would be able maybe to even seal that using MTA, but now you have to wait, a whole bunch of minutes to allow that MTA to set, and then and you're still risking getting more bacteria within that pulp and affecting that pulp at a later state. So the number one thing that we want to try to do is not get into the pulp. Again, no exposure. So how do you do that? How do you prevent getting an exposure? Well, that's what selective caries removal is all about. And when you combine the selective caries removal concept with a systematic approach like the one presented by Dr. Aleman right here, you will see that it'll make a lot more sense. Again, you're seeing on the left-hand side, the outer caries dentin. You can see that that caries extends all the way to the DEJ of this image, of this graft. And you have that outer dentin and you have the inner dentin, the inner caries dentin, which is the more transparent, the more, it still has lost some of its, mineral, but it's still a more mineralized dentin, if you want to call it that way, compared to the outer caries dentin. So what you're seeing on the right-hand side now is the selective approach, meaning you want to make sure that you clean all the caries near or closer to the DEJ. You got to make sure that you can account for this ring, or also called biorim. That's the way that it's called in the literature today. That biorim of dentin, which is 2 millimeters away from the DEJ and surrounding that deep area of dentin. So when you have deep areas of outer caries dentin that you're not removing, because you know that if you remove them, you're going to be very close to the pulp chamber, you're going to selectively remove everything around it. You're going to selectively remove whatever's on top of it. And I'm going to show you exactly how this is done. I'm going to show you what the evidence or the literature suggests today, how to do this in a clinical scenario so that you have a better control of how much you are removing. But the most important thing here is to understand that 2 millimeter periphery around that outer caries dentin, away from the DEJ, so 2 millimeters of nice, healthy, solid dentin around that DEJ is what you want, so that you can create a really good seal around that caries dentin, where we already said we're not going to be able to achieve the best bonding possible. So this is what you're trying to look for at the end of the day. Healthy dentin around an area where there's still some infected and affected dentin. And I'll show you some photos of what this looks like on a real clinical case. Again, this is out of their article, and I just want to show you what they're doing here. You can see this tooth with a lot of caries. You can see the enamel surrounding. You can see that there's a really big rim of caries all the way out to the DEJ here on this mesial aspect of this tooth. And you can see that they did a little graft over here where they left the gray area in the center. That gray area is the affected or infected dentin. That is the deep caries area that is right on top of the pulp chamber. And we can all identify that in a real clinical situation. Now look at the pink area around that deeper dentin. That pink area that is within the limits of the red line is what we call the peripheral dentin, where we want to make sure that we have at least 2 millimeters from the DEJ inward of nice, healthy, clean dentin. That is where we're going to achieve our best bonding within the dentin. And then again, you can see outside the red line, you have that other pink area, which is the enamel. You need to achieve 100% clean enamel. And if you see on the right-hand side, the photo on the right-hand side, you have that caries-free zone that is 2 millimeters within the DEJ. You have that deep dentin, which is still pink. And this is and the reason why they're using the pink color here is because what they are using to remove the caries, and what we should be doing in our clinics is using caries detection dye. If you use caries detection dye and you use a red caries detection dye, you will notice that this detection dye will stain more on the red spectrum, the infected dentin. So when you're removing that deep dentin, you know that the more red it is, you can still go ahead and remove some of that. Once that gets to be more of a pink color, so the stain is now not red but more pink, now you know that you're in that inner caries layer. You're more in that mineralized portion of the dentin that is still affected. I'm sorry, but now you don't have to remove it. That's how you clinically determine what is it that I need to remove and how much I need to remove in order for me to be able to stay away from that inner caries layer. So that's literally the way that you do it from a clinical standpoint. So let me show you this clinical case. So we can all see in this case, I'm not going to restore with an indirect restoration. I'm actually going to restore this with a direct composite restoration. But at this point, and I don't want to give an example of an indirect restoration. I'll do that pretty soon. For now, what I want to do is I want to share with you the way that I go in and I manage caries so that I know that I'm trying to protect, I'm trying to keep really nice and healthy dentin around the caries area. But most importantly, I'm trying to selectively remove that infected dentin and actually leave some of that affected combination of dentin in the deeper sides because I want to maintain tooth vitality. Now, one thing that you want to make sure that you never do is that you don't want to use any soy paste, any type of products that have zinc oxide or eugenol underneath your resin composites, because they're not going to bond well. And that's what you're literally seeing here in this clinical case. So I go ahead, I remove everything. You can see that there's still some caries here on the mesomarginal ridge, but this is after removal of the defective restoration. And you can see that underneath that lesion, even though they had all this combination of biomaterials, you can see that there's still some soft dentin. Just by looking at this photo, we can all agree that this is soft dentin. This is what we see every single day. I've been seeing this for the last 26 years. It is impossible for me not to be able to analyze that dentin and to understand that dentin is caries dentin. That is infected dentin. I know that if I get my spoon excavator in there, I'm going to be able to remove some of that leathery type of a sensation, or that leathery type of feeling on top of that dentin. Now, one thing that I want you to be aware of and be careful with: do I really want to use a spoon excavator in order for me to do this? I would actually stay away from spoon excavators. I would stay definitely away from explorers, because obviously, you may want to use a spoon excavator if you want to have some tactile feeling on your hands. But honestly, just by looking at this, I know that that's an infected dentin. And now I have to decide whether I want to use a carbide burr or I want to use a diamond burr. Now, why am I saying this? We all know, I personally use carbide burrs. And the only reason why I'm mentioning this is because if you decide to use a diamond burr, there's nothing wrong with that, just keep in mind that when you use a diamond burr, you're going to create more smear layer than if compared to you using a carbide burr. And why is this important? It is important when you are now are confronted with restoring this tooth. If you're going to use, like what I'm using today, a selective etch technique, where I'm going to selectively etch the enamel and then self-etch my dentin, you know that your self-etching adhesive systems are not that the acid portion of them, or the acidic portion of them, are not as strong as the phosphoric acid. So you're going to have less chances to remove a thicker a thicker layer of a smear layer. If you use a carbide burr and produce less of a smear layer, your self-etching dental adhesives are going to be able to behave even better. They're going to be able to work better because they have less of this smear layer to remove. So keep that in mind. That is very, very important from a clinical standpoint. That's the reason why I always use metal burrs, carbide burrs, in order for me to remove or to get into these deep areas. Now, what you're seeing here on the right-hand side in red are the areas where I'm going to concentrate my caries removal. Those are the areas I'm going to stain. Those are the areas that I'm going to go ahead and use my carbide burr. And you can see here, once I have removed the caries, my goal was not to get to healthy dentin everywhere. My goal, because I knew this is a young patient, I knew that if I continue working with my burrs in that area, I know I was going to expose the pulp, because I'm right on top of that pulp chamber. So that's what, and I know that we all clinically can make this clinical decision. This is something that we only have to see to in order for us to make sure that we understand this. Think about the age of your patients. If your patients are more on the older, 50, 60, 70, or 80 years old, they're going to have obviously a receded pulp chamber. You're going to have a lot more tertiary dentin there. So you may be able to remove more caries. But on your younger patients, and if you have a young population of patients in your practice, that will completely change. But the other thing that I want you to notice is that look at that little arrow that I drew right there. I'm actually 2 millimeters away from a very nice and clean DEJ. That is the ultimate goal. I knew that I had caries in the interproximal. I needed to remove that mesial wall in order for me to get access to the caries that was on the enamel and on the DEJ. But you got to make sure that your enamel and your DEJ are 100% clean. Now, everything that you see, all that nice and beautiful, young, healthy dentin that you see around these affected, infected areas is the dentin, is that peripheral dentin where I'm going to achieve my best bond. I'm going to have less of an ideal bond on the areas, on the deeper caries areas, but I'm going to have a really, really good bond on that enamel. And why? Because we all know that enamel is the best substrate to bond to. So you want to have 360 degrees all around your cavity preparation enamel so that you can really bond strongly to that and keep your restorations nice and sealed. And this is my final restoration on the upper left-hand side before I remove my band and before I do any occlusal adjustment and any polishing. And on the right-hand side is after my polishing and after occlusal adjustment. So what you're seeing there, the rubber dam that you're seeing on the right-hand side is a rubber dam that I placed after I did my occlusal adjustment, just for me to get a really nice photo and to be able to show you what a completed restoration should look like. But again, what was the thought process behind it here? The restorative material is the least important. The most important thing is the philosophy of caries removal, that we should understand why we're using it and how we use it and how it behaves. So what is my summary from a caries management standpoint? Number one, consider leaving affected dentin in deep areas, even infected dentin in deep areas. Again, if you are risking the vitality of your tooth and your pulp does not have any irreversible pulpitis as a sign, so then go ahead and make sure that you're very conservative at the time of removal. That way you can keep this tooth vital. If there is a reversible pulpitis, there's nothing that we can do. There's a completely different management for that kind of situations. Number two, if infected dentin is present in deep areas that may compromise vitality of the tooth, leave and seal with a dental adhesive. And that's what I just showed you right now. Now, on those deep areas, if you do have deep areas, what kind of dental adhesive would I would recommend at this point? I would recommend a 2-bottle dental adhesive, self-etching dental adhesive. That would be the number one that I would use for situations like this. Dentin 2 millimeters or more away from the DEJ must be caries free. And you just saw an example, so that's very nice and easy to understand. The DEJ must always be caries free, and enamel must always be caries free also. So that's very important so that you can get that peripheral seal in your final restoration. And more important, if you decide to use an indirect restoration. So that's what brings me to my second tip and trick of the morning: immediate dental sealing. So now I'm thinking, okay, I'm not going to restore this tooth with a direct restoration. I need to restore this tooth for whatever reason with an indirect restoration. Now, if you think about this concept, immediate dental sealing, the word is fairly new, maybe 15 years now in the literature. There's a lot of textbooks. Actually, Dr. Pascal Magnier just came out with his second version of his biomimetic dentistry textbook, which is, I would highly recommend if you're interested in learning these topics, highly recommend that textbook, and highly recommend reading all the articles and all the papers out there that are talking about this and all the evidence that we already have and have accumulated in the last 15 years about this topic. So by no means I would consider this a new quote-unquote topic today. This topic has been developing within dentistry for more than 15 years approximately today. So the number one thing that we have to understand is what is immediate dental sealing? Why did it come into play? Now, if you think about one specific thing, when we do direct restorative dentistry, when we're doing direct composite restorations, we're already doing immediate dental sealing. Why? Because you're sealing the dentin the day that you're placing your final restoration. So that is why do we like that? Why do we know that is the best thing to do? Because today we know that the longer we allow that hybrid layer to age, the stronger the bonding we're going to achieve. And if you think about what's keeping these restorations in place is all about bonding. And what we have to do today, in my mind, what immediate dental sealing is all about is about you achieving the best bonding strength possible. Now, that requires a good clinician. That requires a really good dentist. That cannot be done by any dentist out there. It needs a really good understanding of what biomaterials are. So, immediate dental sealing is a concept that we have been using for years because we do that every single day, every time we do a direct restoration. And when we look at the evidence and we say, okay, how long does a well done direct composite restoration, a class 1 or a class 2 direct composite restoration lasts on our patients, and we are seeing evidence 10, 15, 20 years of good behavior of these restorations. And there's a reason for that. The reason is because we sealed the dentin, we achieved the best bond possible the day that we delivered our final restoration. So when you do this, when you use this concept in indirect restoration, the basic idea is that you're going to apply the adhesive, you're going to create your hybrid layer at the time of tooth preparation to seal that newly exposed dentin. Now, you may be asking yourself, why would I seal the dentin? What is the reason behind me sealing that dentin the day of preparation? Well, there's a few reasons, but the most important ones: contamination of the dentin. If you prep a tooth and you put a temporary on, again, I want you to think about minimal preparations. I want you to think about conservative dentistry, which means you're trying to preserve as much tooth structure possible so that you are getting your stiffness, your resistance from occlusion. You're getting your strength on that restoration based out of what the substrate is made of. And that substrate is going to be made of a lot of enamel and a lot of dentin because you're trying to be conservative. This is not about crown preparations. This is about partial coverage restorations. So if you have a partial coverage restoration, you know how difficult it is for you to keep a temporary in that patient's mouth. And every time that temporary comes out, if the dentin is exposed, if the dentin is not sealed, you're going to get bacterial contamination. And by getting that bacterial contamination, not only are you able to get some reaction from the pulp, you may end up having some hypersensitivity, but most importantly, the day of delivery of the restoration, how would you get rid of all that bacteria that's already populated within those dentinal tubules? So that is why it is important to seal the dentin to prevent contamination. You want to seal the dentin the day of preparation because you want to prevent collapse of the hybrid layer. When we were in dental school, how much did they put into our brains that we needed to have all those collagen fibers literally standing up, literally wet or moist, so that they would not collapse, and that way we can now infiltrate them better with the resins that we have in our adhesives. There is truth behind that, and this is one way that you prevent that. If you do delay dentin sealing, you're going to have a fully collapsed collagen fiber network the day that you're going to try to seal that dentin. That would be delayed dentin sealing. That would be at the day of the delivery of the restoration. So obviously, you may have some difficulty sealing your restorations because you did not compensate for that thickness. When you do immediate dental sealing, you're going to make your impression right after that. Your impression is going to literally have the thickness of that hybrid layer incorporated within your impression. So now, if the lab adds a little bit of a spacer there in order for them to allow for your cement, you're going to compensate for the hybrid layer and for the thickness of your cement. And finally, patient sensitivity. That is one of the most that's one of my most favorite advantages of immediate dental sealing. My patients rarely complain about hypersensitivity with their temporaries. If I say rarely, I would say 1 out of every 10 patients may have a little bit of sensitivity. But I have at least 7 out of 10 of my patients that I can deliver these restorations without even numbing these patients, without even numbing the patient. That's how much reduction of the sensitivity I may achieve by sealing the dentin. And there's a reason for that. If you think about the hydrodynamic pressure theory of hypersensitivity, once you've sealed your dentin, there's very little chances for you to make any intra-pulpal or interdentinal tubule fluid movement that can stimulate any fibers within that dentin towards the pulp to create hypersensitivity. So again, all these are good reasons why you want to do that. Now, is there any evidence to say that, one technique is better than the other? Well, there's a lot of evidence out there that suggests that immediate dental sealing is a really good thing to do for all the reasons that I've said right now, but for many others as well. The number one thing that we have found is that immediate dental sealing And when we freshly cut teeth, that is what we recommend doing. We recommend using a dentin bonding agent. In the early stages of the research, they were always using a 3 bottle or a 3-step total X system, which actually was OptiBond FL, which is a great dental adhesive. Now, I would still consider OptiBond FL today on on the teeth that I don't have deep dentin to work with. But if I have deep dentin to work with, and many of my cases today are like that, and you will see some that I will share with you today, then I will definitely go the route of a 2-bottle self-etching adhesive system, so that you have less, you remove less mineral, you have less depth that you have to infiltrate your monomers when you use a self-etching adhesive compared to a total etch technique. So what does the technique look like? And this is where this gets tricky, because yes, I'm not gonna sit down here today to try to convince you, oh, this is very easy to do and you're gonna get used to doing this, day one. No, it's not easy to do. It takes a little bit of skills. It takes a little bit of time. But at the end of the day, I know that if you're listening to this webinar on a Saturday at 11 o'clock in the morning, it's because you want to be a better dentist. It's because we all want to do the best dentistry that we can, and we know our materials. So if we want to do the best dentistry that we can, why are we going to cut short? So there is no shortcuts in this type of dentistry. Now, one thing that I'm going to say right now when I'm looking at this diagram, one thing that I would do and that I would highly recommend, and I am good at isolating, I always isolate. I want to have complete control of my operative field. I would not recommend you do this technique without a rubber dam, because if you do so and you get any bleeding or curricular fluid, you're going to affect the most important thing of this concept, which is sealing nice, healthy, and clean dentin. So in this graph, for whatever reason, there is no rubber dam. I'll show you my personal cases. I'm going to use a rubber dam 11 out of 10 times, because I know that that's the best way I can achieve an ideal substrate in order for me to bond these restorations that are only there because of bond strength. They're not there because of resistant or retention form. So again, step number one, if you're preparing a crown, you want to prepare, a slightly deep chamfer. I would consider this too deep, because you can always go back and clean with a diamond burr your enamel and your chamfer. So again, these techniques, you can modify this as much as you want, depending on the type of dentistry or the type of preparations that you like to do in your office. But first step would be, place your rubber dam or your cord. Again, my preference is always a rubber dam. Then you're going to go ahead, you're going to mark your chamfer, you're going to prep your tooth. Once the preparation is completed, you're going to go ahead and you're going to etch, and you're going to etch the dentin, because what you're trying to seal is the dentin. And because multiple times you're going to have very conservative preparations, if you have enamel exposed, you don't need to seal the enamel. You actually need to go back with a diamond burr and remove any adhesive that may be left over on your enamel, because you want to make your impression of freshly cut enamel. You only want to have your dental adhesive or your bonding resin, your bonding agent, on your dent, right on top of your dentin. So you selectively etch or you total etch, depending on the technique that you're trying to use. Either self etch, or total etch. In this case, they use total etch. You can see that they place in all the dentin. Now you go ahead and rinse. You rinse and dry, and then you go ahead and you just dry the tooth. You want to make sure that you rinse dry. You don't have to leave the tooth completely dry. You want to leave it a little bit moist. You go in, you place in this particular case, they're using OptiBond FL. You place the primer, you place the adhesive. You're going to get this thick layer of resin around that dentin. You apply multiple coats. You can see that some of this is going to go on the enamel. Then you're going to have to refresh that. You're going to light cure that. You're going to blow some air, eliminate the solvent. Go ahead, eliminate the solvent. Make sure that you have a very thin layer. You can remove some of that excess with a periodontal probe, as you're seeing here. I like using very small micro brushes, new dry micro brushes, to remove all the excess. And then you're going to go ahead, you light cure. Once you have light cured your adhesive, now you're going to place a glycerin. So you're going to place something like a block out glycerin and air blocker, so that you have no oxygen, and you're going to go ahead and cure again. The reason why you do this is because you don't want to have any free monomers that haven't polymerized yet on the outer surface. And you're always going to have that, because there's oxygen present in our offices everywhere in our world. So you got to make sure that you use that glycerin, you light cure through the glycerin, so that you can get the best polymerization rate possible. Now you can remove your cord, and prior to removing your cord, you want to make sure that you want to clean that area with a little bit of water and pumice so that you get rid of any of that outer surface that was left unpolymerized, and then you rinse dry and you make your impression. And I'm going to show you the study that actually showed that. So what they did in this technique is that this is another paper that was actually a study published by Dr. Pascal Magnier. And what you can see, what they did here is that they had three groups. Group number one, they had a tooth preparation, bonding agent, and a direct restoration. This was the gold standard. This was the control group. This is the ideal, what we do every single day. Group number two was delayed dental sealing. So they prepped the teeth, they made impressions, they send them to the lab, they temporize them, they send them to the lab, they got the restoration back, then they acid etch, prime, and bond and delivered the restoration. And group number three was the IDS group, the immediate dental seal group, the one that I just showed you the steps. You prep, you seal the same day, you make your impression, you send it to the lab, restoration comes back, you deliver your restoration. So they had these three groups. And what I want to show you is what was the results? What was the microtensile bond strength on these restorations? And I want you to look at the composite, the direct composite group, and the immediate dental sealing groups. You can see that they were not statistically different, but I want you to look at the numbers. 55 to 58 megapascals, respectively, on these groups. So actually, they achieved stronger bond strength with the immediate dental sealing group than they did with the direct composite restoration, but not statistically different. But why am I showing you this? Because when you go to the literature and you revisit and you check what is how strong is that connection between the dentin and the DEJ, you will see that it's around 40, 50, 60 megapascals. So we're almost at the level that we are matching the junction between the DEJ, the dentin, and the enamel, which is incredible. And why is this important? This is so important because we know that over time our bond strength is going to diminish. We know that. We know that it's going to decrease over time. So if you achieve the highest bond strength possible, if you have a really good technique, a really good clinical protocol where you can achieve 58, 60 megapascals of bond strength, over the years, if you get any reduction, you can go all the way to 30 megapascals and your restoration is still well bonded. But what happens on the delayed dental sealing aspect? If you look at the delayed dental sealing specimens, they only achieve 11.58 megapascals. Now, your restoration is still going to be bonded. It's going to be bonded. It's going to be on the patient's mouth. But what's going to happen over the years? What's going to happen 5 years later when that bond strength is going to become lower? Because we know that we have the metalloproteinasas. We all know what happens with our hybrid layer over time. The lower you get, the easier that restoration can debond. And this is crucial when you're only relying on bonding to keep your restorations in your patient's mouth. This is the essence of immediate dental sealing. And this is why I think this is something that we should be doing today in our clinics. Because not only we're being conservative, but we're bonding to the best clinical possibilities we have today. We can do this with the biomaterials and the techniques that we have today. So the conclusions of this study was that when preparing teeth for indirect bonding restorations, immediate dental sealing with a 3-step etch and rinse filled dental bonding agent prior to impression making results in improved microtensile bond strength compared to delayed dental sealing. Now, in this study, what they looked into was, okay, so can an immediately dental sealed tooth affect my impression? And the answer to that question is yes. We know today, thanks to this is one of the studies, there's a couple of more out there, that this does affect your impression materials, PVS and polyethers. Here, they only use Aquasil and they use a polyether, the Impregum Soft. And what they did is that they had 4 groups. In group number 1, they had the control group, which was preparation, unsealed surface. Then other groups were immediately dental sealed. One was immediately dental sealed, no barrier, no pumice. Immediately dental sealed, barrier, and then immediately dentally sealed, barrier and pumice of the tooth prior to the impression. And what we found was that the only group that literally had no problems while taking the impression was the immediately dental seal group, the air barrier, and then the pumice. Those groups, the impressions were without any defects 100% of the times. Every other group, meaning this is just to tell you, yeah, this is not easy. This is technique sensitive. You have to understand every single step. But if you do it right, what the outcome is what I'm looking for, is what are the results. I know this works. I know it behaves well, but I have to follow the rules. I have to follow every single one of the steps. And if I want to summarize the steps today, I know exactly what I need to do. There are some pitfalls. This is not easy. You may have some pooling of the adhesive that obviously will remove, but again, these are all easy to resolve. If you have any pooling of the adhesive on your margins, just grab a fresh diamond burr, go around your enamel margins, remove all of the adhesive around your enamel margins, make sure that they're nice and clean. You're done with that. Adhesives can inhibit set of impressions. That's true. We know how to eliminate that pitfall today. You use an air blocker like a glycerin. You cure through that. You rinse, and then you go ahead and pumice the tooth with a prophy cup. You pumice the tooth a little bit. Just clean everything. Just get rid of any unset monomer, and then go ahead and make your impression. So we know that we can now go over that pitfall or correct any things with these techniques specifically. And obviously, the potential for professional to get locked onto the prep. And I'll show you a very simple technique on how to avoid that from happening. I'm just going to go to the next slide. So again, these are just the do's, the whys. I'm not going to read over this slide because I've went through it, but I just want you to know, if you're cutting dentin, you want to make sure that you think about the burr that you're using, diamond or carbide. If you're using diamond, you want to use a total etch technique. If you're using carbide, you can use a self-etching adhesive. That's why I recommend carbides. You want to make sure that you understand that you need to use either a 3-step technique, etch, prime, and bond, or a 2-step self-etching adhesive with a selective etch technique. You selectively etch the enamel, and then you self-etch the dentin with a 2-bottle system. You want to use, you can always add some flowable composite or just some regular composite to make all your preparations nice and uniform. This will allow you to preserve more tooth structure. If you have any undercuts underneath any cusp, well, go ahead and remove those undercuts with composite. And again, you cover the preparation with glycerin. You light cure through that glycerin to make sure that you eliminate any of the oxygen inhibitor layer. And before your impression, you clean the tooth with pumice and a prophy cup. So that's just for me to review with you in a simplified way the steps that you got to take. Now, this is a very nice, just little. This was actually written in one of the journals, and this was one of the editors of the Journal of Aesthetic and Restorative Dentistry. And what they were trying to talk about is just kind of summarize, or Dr. Swift giving his idea on what immediate dental sealing for indirect restorations really means. And I just want to read out one paragraph that I thought it was very, very important, which is stated that immediate dental sealing is a fairly simple technique. So it's not simple, but it's fairly simple, and it'll get simpler the more you use it. That takes advantage of your best opportunity to get a good bond to dentin while offering additional advantages like reduced patient sensitivity and better fitting final restorations. So there's a lot that we can gain from this technique. We understand that it's not easy. Nothing that we want to do right in dentistry is easy, but we are skilled, we are trained, we understand our biomaterials, we have the biomaterials out there. We can make this happen if we follow a step-by-step protocol. And I'm going to show you one of my cases. You can see what's going on. Fractured mesobuccal cusp, fractured mesomarginal ridge, and a resin composite left in that tooth with some flaws at this point. I'm going to remove all the fractured area. You can see on the right-hand side, I was able to clean everything, nice and clean enamel. I now immediately dentin sealed this dentin using a 2-bottle self-etching system. And then I went ahead and I applied a very thin layer of flowable composite around my preparation just to make everything nice and uniform. Now I'm going to go ahead and put glycerin. I'm going to clean that prep with pumice, and I'm going to make a final impression using a PVS material. Once I get my restoration back, I'm not going to walk you through the process of how to clean the preparation. We have a full webinar on this topic that you can go and revisit, but we're going to clean it with phosphoric acid. We're going to place Monobond Plus. Again, I'm not going to go into the details of the adhesive. There you see me applying the Monobond Plus. Now, this is the day of delivery. This is the second appointment, rubber dam isolation in place. You can see beautiful control of the operative field, very well inverted rubber dam, no curricular fluid, no bleeding, nothing that is going to interfere with my fully beautiful seating of the restoration on beautiful, clean, and healthy enamel. I'm going to go ahead, I'm going to micro etch that dentin. I'm going to use a micro etch with aluminum oxide 50 micron to clean all the remaining cement. I use flowable composite and a little bit of acid on the margin of the enamel on one or two portions of the margin, a little bit of the adhesive there, and I'm going to use flowable composite to bond my temporary restorations. I use it because that's the way that I have found that they do not fall from my patient's mouth. You can see there's nothing retaining that restoration in my patient's mouth other than a little bit of the flowable composite. But before I put my flowable composite and save my temporary, I'm going to use a microbrush and I'm going to put a thin layer of Vaseline on top of my preparation. That Vaseline will be removed. That's why I'm using a micro etcher at the day of delivery of my restoration, so that I can get rid of any oils, anything that was left over my dentin, and make sure that I'm going to bond on very nice and clean, a nice and clean hybrid layer that I created during my first appointment. So on the right hand side, you can see my selective edge. Now I'm going to use again my adhesive, my self-etching adhesive. I'm going to put a second coat, and I'm going to go ahead and deliver that restoration using a resin cement. Then I can go ahead and polish. I can go ahead and adjust the occlusion. I remove my rubber dam, do all the adjustments that I require. Look at that restoration. You can barely tell the transition between the tooth structure on the buccal and on the lingual side of the restoration. It's a partial coverage restoration. You can see the distal marginal ridge is still the patient's own enamel. The distal lingual cusp is still the distal buccal cusp of my patient's tooth. So all I'm doing is partial coverage. I'm just restoring the tooth wherever that restorative material was needed. And this restorative material was chosen as the best material to replace the enamel. This is a lithium disilicate type of onlay restoration. And my final tip and trick, which comes down to the actual preparation. And there's really not a lot that I need to talk about, because as you can see, these preparations are the easiest things to do. All you got to do is remove any undercuts, remove any restorative materials, seal your dentin, and you have a preparation. And try to keep as much enamel as you can around the preparation. If you have 360 degrees enamel, you're going to get the best outcome. But what I do want to show you is the fracture resistance of remaining buccal cusps in maxillary premolar ceramic onlay restorations. This study, I want to share with you, this is my final tip and trick, my final study for today in the morning, which is going to share with you what we call just give you an idea of how much you really need to remove tooth structure in order for you to get a strong restoration. So what I like about this benchtop study was that they had multiple groups, and you can see that some of these groups were never restored. So they only had preparations. They had preparations, and I'll show you the graph. They had preparations that allowed or that kept at least 3 millimeters of enamel from the buccal cusp tip to the actual central fossa. They left 3 millimeters, 2 millimeters, and 1 millimeter, and no restored tooth. Then they had a non-restored occlusal overlay. So they prep a tooth, buccal and lingual cusp, an overlay, but they placed no restorations. And then they had other 4 groups. And all these 4 groups were similar to the first 4 groups, but they were all restored. So they now had restorations that were bonded following these protocols that I'm sharing with you. And then they had one RO group or R0 group, which was a restored overlay premolar. And just so that you understand how the preparations were done, you can see these premolars. They left 3 millimeters of unprepped tooth structure enamel on this buccal cusp. They allowed 2 millimeters. They left 2 millimeters here. They left 1 millimeter here. And this is the full overlay. So they had these 4 types of preparations. 4 were restored, 4 were not restored. And then they had one preparation, an overlay, that was not restored as the control. As all these, 2, these were control groups, 2, 1 restored, 1 unrestored, and then the other design preparations. And what did they do? They went ahead and they put them under this fatigue machine so that they can assess to what level or how many forces or cycles that were needed to actually fracture the tooth, fracture that cusp, that buccal cusp. And these are the results. When you look at this, what you're seeing here in the light orange is the buccal thickness 3, 2, and 1 millimeter. This is the restored group, and this is the non-restored group. So when the teeth were not restored, regardless of the preparation, the amount of force needed to fracture the tooth was 50% less than when the tooth were restored. And I want you to look at this number right here. This green number was a sound tooth. This was the control group, a tooth that had no preparation, intact premolar. And the intact premolar only was able to withstand 685.67 cycles before it fractured. So that's the amount of strength that was needed to fracture that tooth. And I want you to compare that to the 3 millimeter, the 2 millimeter, and the 1 millimeter. All of the groups that had bonded restorations, regardless of the amount of enamel that was left from the cusp tip to the actual margin in the central fossa, were much stronger than the actual sound tooth and double the strength compared to the teeth that were not restored. So this is how bonding really works. This is how strong we can make teeth once we bond these ceramic restorations, regardless of the type of preparation that we have. So the conclusions were that the restored groups had fracture resistance 3 times higher than the non-restored groups. This could be explained by additional strength provided by the bondable ceramic restorations. This study determined that 1 millimeter thickness of a remaining buccal cusp in bondable partial coverage restorations is sufficient to withstand normal use of the tooth without breakage. Why do I like this sentence? Because I want to preserve as much tooth structure as possible. Let me show you this last final case. We're going to remove this implant that is keeping this crown in place. The implant is failing. But before I do that, I want to restore this premolar, which has a distal box, an amalgam fracture with the distal box completely out of the amalgam completely out of the distal box. And you can see it from a side point. You can see where we want to remove this implant. There's a polished color here, huge embrasures. So it's just niche for bacteria, for plaque, and for food to grow. So we got to remove that implant and replace and place a new implant at a different level with the bone graft. Well, you know all that. I'm not talking about implants today. I want you to look at my premolar. So I removed the implant crown. Obviously, the amalgam is just going to fly out of the patient's mouth because the only thing that was keeping that amalgam in place was the actual restoration that was on the implant. So you can see that deep caries. Think about caries removal. There's my rubber dam isolation, beautifully inverted around the premolar. You can see that everything is nice and sealed. Now I have better control of this area. I can go in and selectively remove caries. You can see a little bit of that sub-transparent layer right there, very translucent type of dentin right on top of that pulp chamber, that pulp horn right here. You can see it even better on the left-hand side. I gotta be careful. I don't want to expose the pulp. The tooth is not hypersensitive. The patient had no symptoms on the tooth. It's just deep caries. So I'm going to go ahead. I'm going to now selectively remove the caries. I'm going to selectively etch the enamel, and now I'm going to seal that dentin using a 2 bottles adhesive system, self-etching system. There's the dentin sealed. And now I'm going to build up my core using a composite. I'm going to use a composite core buildup material, and I use a dual cure material for that. And the other thing that I do is I do not like cure my dual cure cold buildup materials. I allow them to set on their own for 5 minutes before I go ahead and hit them with the light. So once I inject them, I wait for 4 minutes, 1 minute approximately that it takes me all the way to inject the preparation. And then I wait for 4 full minutes before I start light curing. Why do I do that? Because I want to affect the least amount of possible the conversion rate of my dual cure resin cement. If I hit it with the light immediately, you're going to get a lot of stress building up between that resin cement, that dual cure resin cement, the dual cure core builder material, and your hybrid layer. I want that to be slow so that conversion rate does not pull or separate my core builder material from my hybrid layer, which is just freshly done. So I wait 4 minutes. And again, there's a lot of evidence on that technique. That's the way that you should be doing it if you want this to work properly well. Again, one more time, this is not easy, but it works well if you do it right. Now I light cure, and then I'm going to go ahead and prep. You can see I do my occlusal reduction, my lingual cusp. Now I'm going to do my margins. And there you can see using the occlusal shapers from Comet. And there you see my final preparation. A little bit of dentin exposed here. I'm going to go ahead and seal that dentin again. And then I'm going to go ahead and make my impression. You clean that. You put the glycerin. You clean it with the pumice. You make your final impression. For this particular patient, I forgot completely to take a preoperative bite registration. So I had to do my temporary by hand. And when I do temporaries by hand, I just use regular acrylic. And there you're seeing my temporary in place. You can see that it's a partial coverage preparation. At this point, I'm putting my margin, my interface between the buccal margin and the buccal cusp as buccal as I can so that I have a nice centric stop on ceramic. That way I prevent my cement from being having any occlusal forces once I deliver my final restoration. And there's my final restoration. So I do a lithium disilicate, very thin occlusal restoration. And you can see that it's very conservative. Again, I'm cleaning the restoration. I'm going to use Monobond Plus. There's a day of delivery. We're going to go ahead. We're going to etch, prime, and bond. And we're going to use, again, the same technique. Here we're using a total etch technique. There is no more deep dentin for me to be careful with. There's my final restoration, the day of delivery. And there you're seeing my occlusal adjustments and my final restoration, final polish. So again, one more time. It's not easy, but it's doable. We have the techniques. We have the materials.